Hello and welcome to this short webinar on the essentials of infection control for emergency medical personnel. My name is Dr. Hudson Garrett, and I'm an assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine. I've also completed the designated EMS infection control officer and actually served part-time in the EMS community as well. This program is really designed to add to the wonderful content that PERCOM already provides. It was a discussion I had with Jane, so hopefully you enjoy it. The objectives of this program are really to look at the top pathogens that we see most commonly in the EMS environment that could cause either us harm as providers or the patient. The second objective that we're really looking at is some basic infection control strategies that will help reduce the risk associated with the three sort of common areas that I see of contamination, which are the hands of ourselves as healthcare providers, the patient, the clinical environment of care, or the patient's skin itself. And then lastly, we'll review some of the basic requirements associated with personal protective equipment so that we can reduce occupational exposure to ourselves and others. There are some EMS regulations that we should all be familiar with. Probably the most notably is from OSHA, which is the Occupational Safety and Health Administration. Its sole purpose is really to actually protect employees, so it's not at all interested in the employer, but it really is whole purpose, if you will, is to protect the people that are actually out in the workforce. And so as EMS providers, things like having access to personal protective equipment or prophylaxis if you are exposed on the job are all spelled out specifically in the rules and regulations. Some of the other information you might be familiar with are its role in bloodborne pathogen prevention, and specifically the Needle Stick Prevention Act, which of course moved us away from the use of typical blunt and sharp needles so that we could actually reduce needle stick injuries in healthcare. The second organization that we're pretty familiar with, which is the CDC, or Centers for Disease Control and Prevention. And this is a public health agency that's obviously federal in nature that looks at both data and research, but also helps us with practice recommendations to protect both the healthcare providers and the public. And then lastly is the Ryan White Act, which has direct impacts to the EMS environment because it mandates that we actually share information on reportable and transmissible diseases when we're transporting patients, but also that we have a designated infection control officer in the EMS setting. So communicable disease transmission is really based on several different factors, some of which we can control and some of those we can't. We certainly can't control patient comorbidities or what they might have. We may not be able to control what we have as providers. We have lots of providers working safely with bloodborne pathogens like HIV or hepatitis, and they can certainly take standard precautions to protect both themselves as well as the patient. When we think about communicable disease transmission, though, we're thinking about things that can be transmitted from one person to another, but given a certain set of circumstances. Some of this is dependent upon things like how much, what is the dose of that? How virulent is the pathogen, meaning how infective, if you will. But how did it actually get in? Is it something that hit mucous membranes? Was it something that was inhaled, ingested? Was it transdermal? And then what is that health status of the host? So if you take a EMS provider that's worked 3 days straight and is immunocompromised due to lack of sleep, well, that's going to certainly increase their risk for potential contraction of a communicable disease. If you have a patient that is immunocompromised, maybe they're an oncology patient and they have HIV or hepatitis, or maybe they just had a recent joint infection or some type of transplant, well, then we have to be considerate of that as well because that can also increase the risk. There are multiple different routes of transmission. Some of them are more common than others. We know that the most common really is contact transmission, where we're touching something or someone, and that can be either in the direct or indirect format. The second, which is really common right now in the influenza season, is droplet transmission. When we think about droplet versus airborne, the big difference is the particle size. And so influenza is a perfect example of a droplet transmitted microorganism that requires us to wear a surgical mask. And that's simply due because the droplet size itself is so large that it can't penetrate the membrane of the mask. Whereas when we shift to airborne transmission, things like tuberculosis or measles, we have to use an N95 respirator mask that is certainly not very comfortable, but it's designed to stop those smaller particles from actually penetrating the membrane of the mask and infecting the healthcare worker. Recognizing that tuberculosis in particular is still on the rise in the United States, it's really important that we are fit tested for our N95 respirator mask. And then if you do have facial hair, that you specifically are fit tested to ensure that you have a mask on the truck that is going to be efficacious if you need it. We also want to mask the patient to reduce risk of transmission, especially in the confined spaces in the back of an ambulance. And then lastly is vector. So if you think about a percutaneous puncture, where maybe we're sitting on the bench seat and we forget that there's a catheter there and then it punctures our skin, this is an example of that as well. There's three basic common sources for infection transmission, and of course there's always exceptions to the rule, but if you take most pathogens that we're going to be discussing or that you're familiar with, you'll find that they're transmitted via one or more of these three common sources. The first and most common is the contaminated hands of the healthcare worker and the patient, right? And so I always think about the 10 deadly weapons being our fingers. And every time we're touching something, whether it's the laptop, the cardiac monitor, the IV pole, the stretcher, a blood pressure cuff, or any other assorted equipment in our truck, we're contaminating our hands. And it's really critical to think about the use of gloves and what gloves do and do not do. They're really that last line of engineering support that help us prevent transmission, but we recognize that there's lots of rips and tears in gloves. And so those are not foolproof solutions, that we have to ensure that we're washing our hands, especially with soap and water when at all possible. The second one is the contaminated clinical environment of care. So this is essentially everything in the truck that is not living. So if it's not us and it's not the patient, then it's going to be in this environment. So our glucose meters, our stethoscopes, pulse oximeters, lead cables, all of that type of stuff that's going to be specifically reusable is going to be found in that clinical environment of care. What we're worried here is to make sure that we clean and disinfect this environment, especially after patient usage. And so we want to take the time when we transfer that patient to the ED or another facility to fully clean out the rig and ensure that it's fully clean and disinfected. And then lastly is contaminated skin. One of our most natural barriers for infection prevention is to actually have intact skin. But as we all know in healthcare, the majority of our patients get some type of invasive procedure, whether it's a peripheral IV catheter, a urinary catheter, whatever it may be, or some type of tube, and that breaks that most natural barrier of the skin. And so we want to ensure that we can actually mitigate that risk by keeping the skin intact when at all possible. There are two different terms related to transmission and risk that I want us to be familiar with. The first one is referred to as infection. We're all familiar with this. This is when a person is actively sick and displaying signs of illness from that particular microorganism. Versus colonization is when a person is simply referred to as a carrier. The organism is in their body, but it is not actively causing signs of infection. So when we think of the word dormant and we hear about someone who's been dormant for years, that's really what we're referring to here. And that may be something like MRSA, which we're all familiar with, or some of the other pathogens like Clostridium difficile that we'll talk about later. But both infected and colonized patients can actually shed bacteria onto nearby surfaces. And that's an important takeaway because it reinforces us to think about cleaning and disinfection, especially when we have a patient that is demonstrating active body fluids, things like diarrhea, vomiting, or the like. So what can we do about this? Well, in the EMS world, we have limited resources, right? And where there's going to be routine exposure to bloodborne pathogens. Specifically, the law, OSHA, states that we have to ensure that we protect ourselves from both blood and what they refer to as OPIM, or other potentially infectious materials. This can be a needle stick injury. This could be blood, body fluid, urine, human bites. All of these are considered risk to us as EMS providers. And so we want to have not only a prevention plan, but also a prophylaxis plan should we actually become unnecessarily exposed in the sort of duties that we have each single day. There are also recommended vaccines. And, you know, while vaccines are a very hot topic and one that we won't have time to go into today, it is really critical to ensure that we all receive the recommended vaccines per the CDC recommendations. There's some basic ones that many of us are familiar with. Certainly the annual influenza shot, hepatitis B vaccination series. Recently, we're thinking more about hepatitis A, especially with foodborne outbreaks. And so this may be an area that you'll see more about related to that fecal oral transmission. And then certainly the MMR, chickenpox, tuberculosis testing, and the Tdap. One thing I'd like to add here is that for years, we've had the sort of wheel approach to TB testing where you would have a little wheel injected underneath your skin, and then you'd have to go back in several days and have that actually read and interpreted. Well, there's now another test that's out there that is a blood draw that does not require that interpretation where you have to go back. And so for those of you that are working, shifts and have other jobs, this is a really great alternative to screening for tuberculosis that does not interrupt your day multiple times It doesn't require you to take off of work to go do this. This is a standard test that's available at most primary care clinics as well as urgent care environments and certainly at the hospitals. These recommendations are typically updated annually, and so you will always see new recommendations come out both for adults as well as pediatric patients. And as healthcare providers in the EMS setting, we want to ask our patients, and especially children and their families, have they actually had the recommended vaccines, because this can help us work through a differential diagnosis. Well, we talked earlier about the meaning of sort of contamination, or should I say colonization versus infection. Now let's think about infected carriers and contamination, right? Contamination is what we're going to see the majority of the times with our equipment. So if we get blood in our jump bag, or if we get blood on the glucometer, or on the bench seat, that's where we actually have visible contamination on a non-living object. Infected actually is where the organism enters the host and actually causes illness and signs of active infection. And then lastly, as we mentioned earlier with people that are colonized, these are carriers, right? People that actually have the disease but are not ill, so they carry that organism, but they're not actively ill. So what and how can things spread? Well, we've got lots of equipment, we've got hands, we've got personnel, we have a confined environment in the back of the truck. And so there is this organization called NIOSH, which is actually part of the CDC, that looks specifically at occupational exposure. Everything from hearing issues, when you think about how loud the siren is, to occupational exposures from needles and syringes, percutaneous punctures, bloodborne pathogen exposures, etc. And so as EMS professionals, it's not just what happens in the back of the ambulance, but it's also what may happen in the patient's home, what may happen at a facility if you're doing an interfacility transport, or if you're on a chopper, or some type of other transport. And as we see many more EMS professionals work in the ER setting, it's important to be familiar with what resources are available in the hospital setting, specifically the different types of PPE, and then how will you handle patients that come in with communicable diseases, especially since most ERs don't have negative pressure rooms that are available all the time. They may have to transfer that person to another area. They may have one or two of those available. So thinking about that as it relates to mass casualty incidents is another area that we should be concerned with. Now, hand hygiene is absolutely the number one thing that we can do to reduce the risk of infection transmission. And there's new organisms out there like Candida aureus that are causing havoc across the United States. And this particular organism can live for many days on surfaces and objects. And it can certainly be picked up via the hands of the healthcare worker, even the gloved hands, but also the patient. And so again, the reminder that gloves and other personal protective equipment are certainly not a substitute for hand hygiene. And so we want to always refer back to our facility protocol that we have available for our agency-specific policy. Right? We also want to practice hand hygiene before we care for a patient as well as after. Anytime we're moving from a clean to a dirty area, it's ideal to remove gloves and sanitize our hands, recognizing that ambulances don't have sinks in the back. An alcohol-based hand sanitizer, such as a Purell, would certainly be acceptable. It is important, though, to note that the CDC recommends strongly that if you have soiled hands, so you have something visibly soiled on your hands, that you actually remove those gloves and then wash your hands with soap and water as quickly as possible. So when we think about hand hygiene after, we want to ensure that we are removing our personal protective equipment, making sure that we decontaminate the area, and also properly sanitize our hands with either an alcohol-based hand sanitizer or soap and water. This is especially important after using the restroom. Soap and water is hugely important here, not because of the efficacy of the soap, but because of the friction that's created when we actually do that motion to remove organisms like Clostridium that actually is spore forming. So when should we wash or sanitize? As I mentioned before, we always want to do this before and after care, certainly after the removal of personal protective equipment. And an alcohol-based hand sanitizer is typically going to be what we have available in the EMS practice setting. But if you can get access to soap and water, especially after you do your transfer of care in the ED, go ahead and use a sink and certainly do that. That's particularly important to use soap and water for patients that have active diarrhea or vomiting. So we're thinking specifically about Clostridium organisms as well as norovirus. This is critically important to stop the transmission. For perspective, norovirus has a very small infective dose that's required. and it can really wreak havoc amongst an EMS agency with a low dose of infectivity to actually, cause illness throughout the workplace. If you have fingernails, this is a big no-no in healthcare, so we want to try to keep those fingernails clean and as short as possible, and preferably no artificial nails. There's been many studies that have linked transmission of bacteria and other organisms, specifically fungus, to fingernails. And so if at all possible, we want to not have these. These can also damage the use of gloves that you might be doing as well. So it's important to follow the CDC recommendations by not having artificial nails if at all possible. Related to disinfection, there's a couple things that I'd like to cover here. The first is that when we have a visibly soiled area, we always want to start with the cleaning process. That cleaning process is simply going to remove soil and bioburden. It's not going to kill anything. So it is simply designed to remove that stuff so that the next subsequent disinfection step will be highly effective. The CDC recommends a minimum of a low-level disinfectant, but preferably an intermediate-level disinfectant. And in some cases, things like laryngoscope blades, if you're using a reusable blade, would need high-level disinfection. And so you want to look at the disinfectant products that you're using to make sure that they are appropriate for healthcare settings, that they meet the OSHA bloodborne pathogen standard, and have that labeling in the back so that you are compliant with federal law. And then, of course, you want to ensure that you can discard of these items in an environmentally appropriate way. So what are standard precautions? Well, these are essentially things that are identified by the CDC as interventions that we should do for every single patient every single time, right? And this starts with hand hygiene, the appropriate use of personal protective equipment, the application of safe injection practices, so one needle for one patient, one time, and discarding of other single-use items, and especially this time of year, practicing respiratory hygiene and cough etiquette. There's multiple different types of personal protective equipment, some of which are available standard on an ambulance, some of which are not. I know in my particular state, there's a lot of PPE that's not necessarily required that I really think should. And we recognize that there are multiple commercial vendors that provide kits that you can actually pull out. And so my rule of thumb is anytime I think there's going to be potential exposure, I go ahead and put on the highest level of PPE necessary so that I'm already prepared for that. So if we think about an intubation, for example, and we might have potential aerosolization of fluids, then I'm not going to just have on a mask. I'm going to also have on gloves, of course, and certainly eye protection. And so it's really critical to ensure that you're familiar with the PPE that is on your truck, ensuring that it fits properly, that you have access to it, and also carry a spare set for the patient or other healthcare providers that might end up riding in with you. The use of gloves during patient care is, again, an engineering control that is not at all a substitute for hand hygiene. We want to ensure that anytime we're touching clinical areas that we're going to actually wear gloves and then discard those appropriately, specifically for wiping down stretchers and glucometers and blood pressure cuffs and all the equipment that we use. And then once we remove that PPE, we want to immediately perform hand hygiene. Contact precautions are sort of our most basic barrier that we talk about, and they're designed to stop the spread of the organism in the first place. So this can include at a minimum of gloves, but in many cases a gown. So if you go into, for example, a nursing home and that patient has known Clostridium difficile, so they're have an active spore-forming bacteria, well, the best way to do that is to ensure that you can't get it on your clothing either. And so always ask the staff what information you can get about that particular patient. What's their history? Are they on antibiotics? Do they have any active diarrhea or vomiting? And when in doubt, you want to go ahead and gown up. And again, this is that most basic intervention here. We also want to communicate, know what the hospital sign says. If it says contact precautions, then this is a gown and gloves. If it's airborne precautions, then you need to wear gloves and an N95 respirator mask. And again, if it's going to be droplet precautions, a surgical mask would certainly be acceptable. And so as you go into emergency departments and other facilities like nursing homes, be familiar with their signage. And if you don't know, actually ask that information. If you ever feel that you've been unnecessarily exposed during your occupational duties, notify your systems infection control coordinator so that they can take appropriate and immediate action to protect you with necessary prophylaxis. As I mentioned earlier, there's this new emergent threat in EMS and healthcare in general, which is called Candida auris. This is a fungus that's actually a yeast that is causing a lot of havoc across the United States and also internationally. that is often found in the blood. These patients can actually have it on their skin as well and serve as sort of carriers, if that. It's found in both hospitals and long-term care settings. And one of the big challenges from a treatment standpoint is that our antifungals that we have available are not actually proving to be very efficacious. And so this is a very difficult organism to get rid of. If you sort of think about a ranking scale, if you will, a bacteria is the easiest to get rid of, a virus second, and then lastly is a fungal organism. And so here we're dealing with a fungal organism, and the treatment is not, as I mentioned before, very efficacious, and it also takes a long, long period of time to even clear the organism. So why is this particular organism something that we're talking about? Well, it can stay on surfaces for long periods of time, and it can also be on the patient's skin. And so we are constantly all day long touching the patient's skin and recognizing that that can then be spread to others. We have that potential risk for transmission. So how should we actually clean and disinfect our unit? Well, the good news is that you should use a standard sporicidal agent. The most basic agent that you can have accessible to pretty much all of you is going to be 1 to 10 dilution of bleach. So if you've got something like a Clorox that's actually a bleach solution, that would be totally appropriate for that. But anything that has a Clostridium difficile claim would be acceptable for that. We also want to ensure that we know what that contact time is. How long does it take that disinfectant to kill that particular organism? It may be 2, 3, sometimes 5 minutes, and we want to ensure that that solution is left on there so that we can appropriately handle that. Clean all equipment, know who used what and when, and make sure that before it's replaced and used on another patient, that we have properly decontaminated it fully, starting with cleaning and ending with disinfection. So if we're dealing again with Candida, again, we want to use a sporicidal agent in this particular setting. Every single patient can have risk. Every single one of us can have risk. And so going back to our standard precautions, we want to ensure that the cleaning and disinfection of equipment is happening every single time. So if we're taking a patient in a wheelchair, we want to wipe that down. If we have a stair chair, same thing. Backboards, our laptops, one of the things that makes me cringe is when I see EMS providers typing on the laptop with gloves. We recognize that computer keyboards have tremendous risk, and pathogens can grow in there pretty often. So we want to ensure that we're taking care of that through routine cleaning, disinfection, and ideally removing our gloves so that we're not contaminating the unit further. Let's talk about meningitis. Meningitis is spread via direct contact with infected nasopharyngeal secretions. The contact time of 8 or more hours is typically what causes transmission. However, the incubation period, the time that it can sort of cook in your body, if you will, is between 2 and 10 days. Its communicable period can vary from days to weeks. And certainly from a management standpoint, we want to place a mask on this patient. You do not have to use a respirator mask. You can use a standard surgical mask or be acceptable. And then you want to follow regular standard precautions. Tuberculosis, as we mentioned before, is making a comeback in the United States, especially in the form of MDR TB, which is multi-drug resistant. This particular type of TB is resistant to many of the antibiotics that we have, and it is hugely problematic for us. As a reminder, tuberculosis is transmitted via the airborne route, and so an N95 respirator type mask would be indicated for both you and for the patient. That incubation period is between 4 and 12 weeks, so this is hugely problematic for EMS providers because you have such a short duration or interaction with that patient that you may not get notified for weeks and sometimes months later. There is good treatment available for most tuberculosis, but there's a very low rate of compliance, especially in the homeless population and some of the other migrant populations that we see across the United States. So you'd want to place a mask on these patients. An N95 respirator would be acceptable here for yourself, and you could put a surgical mask on the patient as long as they can tolerate that. Preferably, you would put an N95 respirator on the patient as well, but many of these patients will not be able to tolerate that, and so you want to at least put a respirator on yourself, and then, of course, administer oxygen and ventilatory support if needed. From a decontamination standpoint, if you have a tuberculosis patient, you'd want to ensure that you allow plenty of time, preferably 30 minutes to an hour, to allow that ambulance to completely get all of that atmosphere out of there and run the air conditioning and the ventilation system the whole time that you're transporting that patient. Influenza is hitting us pretty hard now, not as hard as it will be probably later, but this is a droplet transmitted viral infection with an incubation period of 1 to 4 days. However, somebody can actually be communicable from the day before their symptoms until 5 days after onset. And so this is one of the reasons that if you have the flu or you have a coworker that they suspect has the flu, they need to stay home, right? And again, we want to place that mask on the patient. A surgical mask would be acceptable here. The best way we can prevent the spread of influenza is to get that annual flu vaccination. And you can get antiviral drugs. The FDA just actually approved a new antiviral drug, bringing our sort of plethora of treatment options up to 3 that can be effective if it's actually offered within 48 hours. Scabies is pretty common in the EMS setting, and it's transmitted via skin-to-skin contact. The incubation period for this particular disease, if you will, is 4 to 6 weeks. And this is actually communicable until the mites and the eggs are destroyed. And so there's a lot of commercial solutions that are over the counter that will help with this. And then there's also prescription options here. So when you're dealing with patients, especially in the nursing home environment that have scabies, you want to make sure that you wear contact precautions, including a gown, and discard of that promptly. And there's really no disinfectant that's going to be effective against scabies. So it's really about physical removal and actually cleaning that ambulance from top to bottom. From a management standpoint, you want to wear your standard precautions, as we've mentioned multiple times. And Lindane is actually the topical treatment that is typically prescribed related to this, and your linens and all those other types of things you'd want to discard and not transport those back to the station with you. If you have a patient that has lice, there are multiple different locations that lice can be found, but we typically see it in the pubic area, and this transmission is most often through intimate or sexual contact. So this sort of brings up the questions about if a child has lice in that area, then we might have to think about getting Child and Family Services involved for potential investigation. The incubation period for lice is 8 to 10 days after the eggs have hatched, and the communicable disease, very similar to scabies, is until all of the lice and eggs are completely destroyed. So the same treatment or sort of priorities, if you will, as scabies, with the exception that the prescription is a permethrin cream that is highly effective, especially when prescribed very early. There are multiple different hepatitis viruses. I'm going to focus on the 3 that are of the most concern to EMS providers, but there's hepatitis A, B, and C. It's important to note that both B and C are bloodborne transmitted viruses, whereas A is fecal and oral. There is a vaccine available for hepatitis B as well as hepatitis A, and hepatitis C recently in the last 2 years has had an FDA cleared drug treatment that is highly effective, but it is extremely expensive at completely eradicating the hepatitis C virus. And so it's always important to note that you want to treat all patients the same by following standard precautions. And certainly if there's going to be potential exposure, if you will, to blood or body fluids, you want to make sure you also take eye protection as well as the traditional contact precautions like wearing gloves. HIV, of course, has been around since the 80s and is transmitted primarily through blood and other body fluids, and it attacks the immune system. The communicable period is unknown at this point, and there is certainly no vaccine available for this. And seroconversion, meaning that you actually test positive, typically occurs within 3 months after exposure. There are multiple different management options out there medically, and there's also prophylactic options should you be exposed during the course of the execution of your duties. And so this is not something, if you get stuck by needle and syringe on a Friday, where you wait to contact your primary care or employee health provider until Monday. You want to get this taken care of the same day within hours. If there is a reasonable risk of exposure and transmission, there are prophylactic medications that we can place you on to mitigate that potential seroconversion. And this is really, really timely that you take care of this immediately. Norovirus is one that I mentioned earlier in the program that, again, is fecal oral transmitted. It's a person-to-person transmission. The symptoms typically appear within 1 to 2 days. The problem with this is that there's lots of aerosols created from the vomiting and diarrhea. And so not only do you want to wear your gloves and gowns, but you also want to do good hand washing with soap and water. And then these patients require a chlorine or sporicidal agent from a disinfection standpoint to eradicate that. And so a bleach solution would be the most appropriate in the EMS practice environment. MRSA stands for methicillin-resistant Staph aureus. This is one that we are all very familiar with in the execution of our duties, and it has pretty wide incubation time period. And secondary infections can certainly occur after blood infection. So the most common presentation in the EMS environment of MRSA is going to be a skin lesion. It can look like a spider bite. It can look like a wound, just a regular wound with lots of drainage associated with that. We see this very commonly with athletes, nursing home patients, as well as sometimes with sexual activity as well. Most of these superficial skin infections do not require systemic antibiotic treatment, but we can actually do an incision and drainage to sort of eradicate that and allow that bacteria to leave the body. But in some cases, you do need antibiotics, and we're finding more and more drug resistance, unfortunately, to MRSA due to the overuse of antibiotics in our society. Standard precautions would be appropriate here, and there is no post-exposure treatment because this is a bacterial pathogen. So most of the times when we think about prophylaxis, we actually see this with our viral pathogens like HIV and sometimes hepatitis. C. difficile, you may be familiar with. It's had a name change recently to Clostridioides difficile, just based on some changes with the microbiology analysis of this. But this is a spore-forming bacteria that is pretty similar to norovirus that causes watery diarrhea. This can also cause something called toxic megacolon. And the most typical cause of this is actually overuse or inappropriate use of antibiotics. Historically, the treatment of this has been more antibiotics. So if you just heard me correctly, we're thinking about an organism that's caused by the inappropriate use of antibiotics, and our traditional treatment has been more antibiotics. So that's sort of an oxymoron. And so I'm pleased to report that there are multiple different other treatment options, most notably something called a fecal transplant, where healthy stool is taken from a donor and then instilled through a capsule or an enema to actually recolonize the affected patient's gut. And rather than have a 50% recurrence rate with traditional treatments with antibiotics, the recurrence rate with this treatment is usually between 5 and 10%, which gives the patient a much better chance of not living a lifelong sort of route of disability. Gloves and hand washing with soap and water is important here, and similar to norovirus, as I mentioned, you can use a chlorine-based solution to actually disinfect these surfaces. Measles is another one that's back on the radar here, and I always have the rule of thumb is if my patient has a fever and or a rash, I'm going to put a respirator mask on them and myself until I prove otherwise. And so measles is extremely communicable. It can infect hundreds and hundreds of people, and we've seen this with outbreaks at places like Disney World because it's an airborne and aerosolized droplet. It's spread via contact with nasal or pharyngeal secretions, and the incubation time period is about 10 days. But the communicable time period is from the first symptoms to about 2 days after that rash develops. So again, if you present especially a child or an adult with a rash, it's not going to ever hurt to put a mask on them and put a mask on yourself. There is only supportive care available here, so there's no direct treatment associated with that. And you certainly want to wash any areas that you have contact with and then launder any soiled items, just as we did with anything else. I wanted to leave you with a couple different educational opportunities that offer CEs. These are actually from Medscape as well as the CDC. And you'll notice here it's really titled about what you need to know about infection control. Each of these programs is half an hour each, so they're really quick to do. And you can see the 6 that are available there. One of the ones that I like the most is really about infection prevention, the hierarchy of controls approach, because it really goes through much of what we talked about in this short program, but helps us sort of think about it mentally, right? What are the first, second, third, fourth steps that I'm going to take to protect myself and protect my patient? The web link is available there, and these activities are free of charge for you to actually take. As we wrap up the program, there's a couple sort of key areas that I'd like to think about as we end our time together. The first is that an infection being transmitted takes a host of different things happening, right? It's not just one specific event. It's not just missing hand washing. It really takes sort of a domino effect that leads to communicable disease transmission. Many of these things that we've talked about can be transmitted person to person, but a lot of that is dependent upon us as well as the patient and our immune systems. And that risk of infection transmission is also dependent upon the dose, how virulent it is, what mode of entry was it? Was it a direct splash to the eyeball, or was it something that splashes on intact skin? And then what's that host resistance, right? And we recognize that the human body itself provides multiple different defenses that will help us ward off potential infection. As we summarize, everything that we've talked about today is a shared responsibility. It's not just the EMS crew, it's not just the hospital, it's not just the patient, it's not just fire and police, but it's really how do we protect each other, right? As a public safety team and family, this is a shared responsibility. We want to take any and all steps to protect ourselves, our crew, as well as the patient, recognizing that every time we go into a scene, we want to clear it for safety. The same is true from an infectious disease standpoint. And we can really summarize by thinking about the three basic areas, right? Perform hand hygiene, make sure we keep the clinical environment as clean and disinfected as possible, and keep the skin intact. A lot of this is going to be based on our hand hygiene guidelines, following standard and contact precautions, and cleaning and disinfecting the contaminated areas of the unit. If you do have any questions, I'm more than happy to answer those for you. My email address is listed here as hudson@hudsongarrett.com, and I hope that you've really enjoyed this program and have found it informative as you go out into the EMS practice environment. Thank you very much.